Welcome to Short Explainers, the high-yield review series for the M3 clerkship. Today's topic is COPD, chronic obstructive pulmonary disease. Whether you're prepping for rounds or your shelf exam, you'll see this one everywhere. By the end of this video, you'll understand what COPD really is, why it matters clinically, and how to manage it. This video is for educational purposes only and does not constitute medical advice. All patients should consult with their healthcare providers about any health concerns. Here's the thing about COPD, it's not actually one disease. It's three pathologic processes that can happen together or separately in response to noxious inhaled exposures, most commonly cigarette smoking. You've got emphysema, which is destruction of the lung alveoli with permanent airspace enlargement. You've got chronic bronchitis, which is a clinical diagnosis defined by chronic productive cough for at least 3 months per year for 2 consecutive years, typically caused by mucus gland enlargement and goblet cell hyperplasia in the large airways. And you've got small airway disease, where the small bronchioles become narrowed and reduced in number. Most COPD patients have all three to some degree, but the mix varies. Some are more emphysema predominant, others have more airway disease. The hallmark of COPD is airflow obstruction. Spirometry shows a reduced FEV1, forced expiratory volume in 1 second, and critically, a post-bronchodilator FEV1 divided by FVC below 0.70. The post-bronchodilator part is key. It distinguishes COPD from asthma. The mechanism, smoke exposure, causes inflammation, mucus plugging, airway narrowing, and alveolar destruction. That airflow obstruction is largely irreversible. In asthma, you get full reversibility with bronchodilators. In COPD, you get some improvement, but the obstruction doesn't fully resolve. Cigarette smoking accounts for about 80% of COPD in the United States, and there's a dose-response relationship. Pack years is the most significant predictor. But here's what's important. Pack years only explains about 15% of the variability in lung function, which tells us genetics and individual susceptibility matter enormously. The GOLD criteria, that's the Global Initiative for Chronic Obstructive Lung Disease, classify COPD severity into 4 grades based on FEV1% predicted. GOLD 1 is 80% or higher, GOLD 2 is 50 to 79%, GOLD 3 is 30 to 49%, and GOLD 4 is less than 30%. But here's the modern shift. Severity is no longer about FEV1 alone. It's based on symptoms measured by the MMRC dyspnea scale or the CT score and your history of exacerbations. You're about halfway through this review, so if you're finding this helpful, take a second to hit like and subscribe. It helps more students find these videos and keeps the series going. Clinically, the 3 cardinal symptoms are cough, sputum production, and dyspnea, usually exertional at first, then progressive. Patients often minimize symptoms for years before seeking care. On exam, early disease shows nothing. That's why you need spirometry. In severe disease, look for a prolonged expiratory phase, barrel chest from hyperinflation, and diminished breath sounds. As the disease progresses, patients develop resting hypoxemia and eventually require supplemental oxygen. Comorbidities are huge here: cardiovascular disease, osteoporosis, depression, anxiety. Screen for them all. If you only screenshot one slide, make it this one. Here's what drives management: smoking cessation, oxygen in hypoxemic patients, and in selected emphysema cases, lung volume reduction surgery. Those 3 interventions improve survival. For stable disease, the GOLD algorithm matches therapy to symptoms and exacerbation risk. Minimally symptomatic patients start with a short-acting bronchodilator as needed. If symptoms persist, step up to a long-acting bronchodilator, either a LABA or LAMA, or combine both for more symptomatic patients. If exacerbations are frequent, add an inhaled corticosteroid. But here's the key modern update. ICS benefit depends on blood eosinophil count. Patients with eosinophils above 300 benefit most. Those below 100 don't benefit at all. Triple therapy, LABA plus LAMA plus ICS, reduces mortality in selected patients. Acute exacerbations happen when airway inflammation worsens, usually triggered by viral infections, new bacterial strains, air pollution, or PE. Clinically, the patient develops increased dyspnea, increased sputum production, often with change in sputum color and sometimes fever or systemic symptoms. Management is straightforward: nebulized beta agonists and anticholinergics for bronchodilation, antibiotics for moderate to severe exacerbations, typically 5 to 7 days, and systemic corticosteroids, which reduce length of stay and speed recovery. Hospitalization is needed if there's respiratory acidosis, worsening hypoxemia, severe underlying COPD, significant comorbidities, or the patient can't be safely monitored at home. If you found this helpful, please like and subscribe, and turn on notifications so you don't miss future videos in this series.